We're live.
Hello, everyone. I'm Betty Farrell, and I'm the chair of this study and of this committee, and I would like to welcome everyone to this session. The task that is being undertaken by this committee of the National Academies of Sciences, Engineering, and Medicine is to examine how our nation delivers, finances, regulates, and measures the quality of nursing home care. The committee's full official statement of task can be found on the project website at the National Academies. Today's open session will include a presentation by Dr. Donald Berwick, President Emeritus and Senior Fellow at the Institute for Healthcare Improvement. I want to note that this is an open, on-the-record session. Individuals from the public have been invited to attend as observers, and we will not be entertaining questions from the floor. But please do note that anyone can submit testimony or other materials to the committee at any time, and these documents will be placed into the committee's public access file. You can submit this information through the project website. I also would like to remind everyone that this is an information gathering session. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee has made no conclusions, that it would be a mistake for anyone to leave thinking that today. Otherwise, we want to move forward and be open to all input and suggestions. Comments made by individuals, including members of the committee, should not be interpreted as positions or conclusions of the Academy. In addition, committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal views. Before we hear from Dr. Berwick, I'd like to ask each of our committee members to briefly introduce themselves and also note that their bio sketches can be found on the project website. So we will begin these just brief introductions with Gregory Alexander and then proceeding with our roster.
Good morning, everyone. I'm Dr. Greg Alexander. I'm the Helen Young Kafsona Professor at the Columbia University School of Nursing. Nice to meet you.
And my name is Mary Ursak, and I am a professor in the University of Pennsylvania Schools of Nursing and Medicine with a joint appointment at the Department of Veterans Affairs.
Good morning. I'm Colleen Galambos. I'm the Helen Bader Endowed Chair of Applied Gerontology at the University of Wisconsin-Milwaukee, and I also have an appointment with the Medical College of Wisconsin. Happy to be here.
Hi, everyone. I'm David Grabowski. I'm a professor of healthcare policy at Harvard Medical School.
Hello, I'm Kathy Greenlee. I previously served as the U.S. Assistant Secretary for Aging at Health and Human Services and the Kansas Secretary of Aging. I have my own consulting business at this point.
Good morning. I'm Lisa Kaplowitz. I'm Deputy Health Director for Arlington Public Health, Arlington County, Virginia.
Good morning, everyone. I'm Tamara Konecka. I'm a health economist and a professor at the University of Chicago, Departments of Public Health Sciences and Medicine.
I'm sorry, it says my host has stopped my video, but this is Chris Miller, and I hold the long-term care professorship in nursing at the University of Minnesota School of Nursing.
I'm Marilyn Rance, and I can't start my video either. I'm at the University of Missouri. I'm a professor. In nursing and also appointment in family medicine.
Hello, I'm Deb Saliba. I'm a professor of medicine and geriatrics at UCLA. I also have an appointment at the Veterans Administration, where I work in the Center of Innovation and at the RAND Corporation.
Hello, this is Bill Scanlon. I'm a consultant with West Health and a member of the Medicaid and CHIP Access and Payment Commission.
Hello, I'm Philip Sloan. I'm a distinguished professor of family medicine geriatrics at University of North Carolina at Chapel Hill, and I co-direct a research program on aging, disability, and long-term care.
Good morning, I'm David Stevenson, a professor in the Department of Health Policy at Vanderbilt University School of Medicine. Glad to be here.
Hello, Jasmine Travers. I'm an assistant professor at the Royal Myers College of Nursing at New York University. Very happy to be here.
Hi, my name is Reginald Tucker Seeley. Can't get my video to work either. And I'm the Edward L. Schneider Assistant Professor of Gerontology at the University of Southern California.
I am Rachel Werner. I am a professor at the University of Pennsylvania in the School of Medicine and at the Wharton School, and I have a joint appointment at the VA.
Thank you, everyone. I think our committee is so interested in hearing from you, Dr. Berwick, because as you know, we are just beginning our work, and following your presentation today, we will dive into begin to think about quality of care in nursing homes. And so we're so grateful that you could be with us today. Dr. Berwick's bio is available on the project website. And as I mentioned, he is the president emeritus and a senior fellow at the Institute of Healthcare Improvement. I think with confidence, I can say every one of us on this call today is aware of your important contributions that have guided quality healthcare in so many areas. And so we're really grateful that you can be here and look forward to your comments about how we can best approach quality of care in nursing homes.
Well, thank you so much, Dr. Farrow, and all of you for the chance to join you. It's always an honor to get to speak with the National Academy Committee, and thank you for your service there. And I couldn't think of a more important problem or one more obdurate. It's been facing our country so long, and we've got to make progress. I've got to give a shout out also to my former Obama administration colleague, Kathy Greenlee. She's a magnificent public servant from whom I learned a ton, and a pleasure as a colleague. And it's so nice to see you, Kathy, at this committee. You've got quite a committee here, and I'm not sure how much I can add to the heft you're going to bring to this problem. Dr. Farrell, what I decided to do was a kind of two-part presentation, and I'll try to keep it short because I know you want to get to questions. The first is I've got you asked me a bunch of questions. Lorraine and Tracy sent me probably 10 questions that were harvested from your group, and I can give you my opinion in response, but the opinions won't make sense unless I give you some of the background of kind of the theoretic framework that I use for better or worse when I deal with the issues of proven and complex systems. So I'm going to share my screen if I could have privilege of doing that, and show you, to walk you through this. So the first part of my conversation with you is going to be about the framework that I use for thinking about improvement at scale. And then the second part will be taking your questions and going through some of them one by one with quick answers based on that framework. Okay, so first, this is sort of like a 5-minute lecture on improvement and sciences of improvement. Now, the basics of improvement, as everyone on this call knows, always start with aim. You never improve without aim. So the most important initial step in improving nursing home care quality is to get really clear about what we mean, what we're trying to improve. The National Academy of Medicine, Institute of Medicine, famously back in 1999 and 2001, published these two reports, To Err Is Human and Crossing the Quality Chasm. And these were a gift to the nation. A committee I was privileged to serve on that said, well, there are 6 aims for improvement: safe, effective, patient-centered, timely, efficient, and equitable care. Safety means we stop harming people. Effectiveness means we align care with science. Patient-centeredness means we empower, we give more power to patients and focus on what matters to them. Timeliness is reduction of delay. Efficiency is waste reduction, which is a quality. Cost reduction is a quality. Certainly could have that on the screen for nursing homes. And then equity is closing racial and socioeconomic gaps in status. In 2006, my colleagues Tom Nolan and John Whittington at the Institute for Healthcare Improvement raised the stakes on that. Everything I just showed you from the National Academy of Medicine, this stuff is parked here under experience of care. It's better care for individuals when they're in care. The second part of the triple aim from Whittington and Nolan is improving the health of populations so that there's less demand for care. And the third is reducing per capita costs, so there's less waste. And this triple aim, better care, better health, lower cost, became a kind of almost mantra in the improvement world that I live in, and now has spread worldwide. So this morning I was working with the country of Singapore, which uses this framework basically to decide on its goals for its national health system. You find that all over the world. A job for your committee, of course, and you know this at the start, is if you're going to tackle improving nursing home care quality, you have to decide what are the aims in improvement. And the clearer you can get, the better. Maybe you can adopt the Institute of Medicine frame, maybe you want to use triple aim, or maybe you want to come up with your own. So that's almost the easy part of improvement, essential. The more important and more controversial part, which I will need to refer to in order to address your questions, is methodology. Now that would be a 1 week course, not a 20-minute talk, but this is a framework that serves well. It comes from Dr. Joseph Duran, who was one of the great scholars of improvement of the last century, an amazing man, a chess grandmaster, author of dozens of books, and a real scholar. Duran set out at one point what some people refer to as the Duran trilogy, which is understanding what it is to think about improvement in nursing homes or anywhere. What is the strategy for improvement? And this is a diagram I drew from his work, but it says that there are basically 3 aspects of improving any system: control, improvement, and he called this planning. I've called it invention. Quality control is getting outlier problems under control. So the metaphor is when you drive your car, if you have a flat tire, you better pull over and fix the tire. It's not part of normal carring or driving, but it has to be fixed. That's quality control, getting things stable. Then there's this yellow area, quality improvement, which is the continuous learning process that the Institute of Medicine has written about in National Academy in its series of reports on the learning healthcare system. This is all learning. This is continuous development of better processes and ways of approaching problems. And then this green is meant to represent de novo invention, new ways to do things. We're seeing this, of course, happen fast in the COVID pandemic as telehealth and telemedicine have just soared. That's not improving the existing system. It's a new system, which comes, in this case, from necessity. Duran's assertion is that any complete approach to improvement in nursing home industry, if you want, or in making, my wife and I are trying to make better pea soup, all should have this portfolio: a small amount of work on control, getting things back in order, because after all, tires aren't usually blown. A large amount of work on continuous learning, and a small amount, but important amount, on inventing the new way. The problem in the world of improvement that I deal with globally and have for 30 years is that that's not the way the world tends to view the problem. The way the world tends to view the problem is more like, find out what's really bad, find all the flat tires, and then fix them, as if that is the approach to improvement. It's called, in the industry, it's called reliance on inspection to improve. It means you watch a population, you look for something screwy, and then you act on what's screwy. It's a bankrupt approach, almost bankrupt. Of course, you need to be diligent. If there's something really terrible, you better fix it. But there's nothing about this approach that tends to change the basic characteristics of the enterprise you're engaged in. The basic characteristics of the enterprise are embedded in the enterprise. They're not outlier characteristics. Nonetheless, most improvement agendas look much more like this. They're not the balanced view that Duran is counseling in approximately this proportion. They're an unbalanced view with excessive reliance on control, metrics, accountability, and fixing damage, fixing bad things, with little energy left over for learning and not much energy left over for invention. And this is actually not a bad representation of what it feels like most of the time in most actually most industries, but also in healthcare. Go visit a hospital and they'll tell you about the amount of reports they have to make to somebody about how things are going. Follow a nurse through her day and she'll tell you what percentage of her time is being put into just filling out reports and forms to, quote, assure things. Years ago, late 1950s or 60s, Bill Schirkenbach at General Motors drew this, what he called the cycle of fear, which is the sociologic consequences of approaching improvement as if it were an inspection problem. What happens is the inspector comes, the system fear grows, workforce especially gets frightened or defensive. They fight back, they kill the messenger. The quality assurance people are not generally invited to parties. But more importantly, the system gains control of information. You end up with a massive effort of gaming in which the inspected party tries to get control of the information that can be used to hurt them. I have many stories of that. The one I usually tell is visiting a hospital, a small hospital where the Joint Commission was to show up, and the hospital was quite littered. There was a lot of stuff in the corridors, and the CEO was walking me through, said, you know, the Joint Commission is coming here next week. We definitely get a citation for this, but I've got the problem solved. We've hired a moving company. They're going to come to the hospital, put all this junk in the moving van, drive around the city for 3 days while the Joint is here. And when the Joint Commission leaves, it'll all come back. That's a true story. And then what happens is all of this stuff is embedded inside the organization. So the relationships between the management and executives on the one hand and the workforce are all controlled by this reporting and defensive maneuvering. The consequences of this reliance on inspection is this: measurement goes wild, becomes very, very expensive, double-digit costs. It's basically measurement is stealing resources from production and from improvement. You end up in an accountability dialogue which replaces the trust on the basis of which real learning depends. Generally, the patient gets blamed in healthcare. In the end, the gaming leads to people saying, well, that's the fault of the patient. Therefore, we try to skin in the game plan, which is also empirically bankrupt. And then because you've got to inspect, that's what all the measurement's doing. You've got to have all these standards, and you end up with manuals and standard specifications that become very onerous and excessive. And by the way, impede quality because patients don't come in standard form. They come one at a time. And the ultimate version of this is to rely on markets. So just, well, let the market do it. The market will do the inspection, and somehow a magic will happen and things will get better. The world I live in for 30, 40 years of work on improvement says that this approach is probably not going to work. The reason is that every system is perfectly designed to achieve exactly the results it gets. Patient satisfaction levels, death rates, infection rates, pressure ulcers. Whatever we've got now, that system is perfectly designed to produce that pressure ulcer rate, perfectly designed to produce that medication mishap rate, perfectly designed to reduce that COVID death rate. If you want better, you've got to have a new system. So all improvement in the modern world that I live in is improvement through change. There are all sorts of ways to help a workforce or a segment of an industry learn how to make change. This is the model that the organization I used to lead, the Institute for Healthcare Improvement, has used for 2 decades now. It comes from the Improvement Guide, which is a product from a resource from a group called Associates in Process Improvement. It involves 3 components. You've got to have an aim, decide what you're going to accomplish. We're going to reduce pressure ulcers. How would you know that a change is an improvement? You should probably count pressure ulcers. And what could we do differently that would result in improvement? Well, let's find out who maybe in the country has the lowest pressure ulcer rate and how did they do that? And then let's try to learn that and bring it back to our place and do this kind of getting on the bicycle, plan, do, study, act cycle. That's just a mnemonic for getting on a bicycle. The kid says, I want to learn to ride up a hill. That's my aim. I'll count the scrapes on my knee, or I have a stopwatch. I'm going to ask my father my mother how to go faster, and then I'm going to try that. And then I find out if it works. And if it works, I'll keep it. And if it doesn't work, I'll go back and find out a different approach. Most of the sociology in healthcare, and even more so in nursing homes, cannot tolerate this model. It will be toxic to the model. because of the current levels of fear and stress, for example. No child learns much when they're scared, and certainly not when they're exhausted. And so it takes a sociology, it takes a supportive, nurturing system to allow continuous learning to occur. One form of that is this breakthrough series. It was the approach developed by IHI, my organization, my old organization, about 1996. It's now pretty much worldwide. It's the collaborative model of improvement in which one picks an aim, decide to work on pressure ulcers or better cardiac surgery or end-of-life care. You get people like Kathy Greenlee in the room and you start saying, well, what's the best known about it? Who knows the most? What are some of the ways to do this better? Meanwhile, you recruit in participant organizations, 30 hospitals, 100 hospitals, 150 health centers, and you have them set up teams, and then they come together for these learning sessions where they begin to hear from the best science. They develop their own plans for change. They exchange ideas. They go back and try some of the stuff. They come back and talk about it. By then, they're teaching each other, and you end up with a sociology in which the changes don't just come from the experts, they come from the practitioners who come together multiple times and then celebrate or announce, make known what they've learned with all support system. This kind of approach to collaborative improvement has been around now since 1996 at least, pretty widely used, and it has many different forms, but this is a learning culture which can support the experimentation and the local lessons learned that have to be put into place. This stuff works very well, and I obviously I'm a champion for it. I've been involved with teaching and learning it and practicing it for years. And as Kathy may know, when I came to CMS, I tried to bring this kind of improvement thinking into a federal agency, which was avid for it, hungry for it. I can't tell you the number of staff that began to learn and use systematic improvement inside the agency. And we also had set up the Partnership for Patients, which was founded more or less on this framework, which eventually involved thousands of hospitals around the country on patient safety. This is how it played out in England in the early 2000s. This is Sir John Oldham, a GP who practiced these methods. Tony Blair put him in charge of primary care improvement in the primary care development team in the UK and the National Health Service. Within a year, John Oldham had set up 11 regional support organizations for continuous learning. He involved 1,000 practices initially in the UK, covering 7 million people and with 7 million patients. And within a year, they would reach 32 million practices covering 32 million patients. It's the largest improvement program in the world at the time. And this is what it looked like. This is waiting times in general practice all over the English National Health Service, wave after wave of collaborative, reducing waiting times substantially. The same approach was used by John Oldham for improving cardiovascular outcomes, cancer outcomes, orthopedic waiting times, and so on. Here's another example. Scotland, interestingly, as a nation, Scotland adopted a continuous improvement model as national policy in their National Health Service. One of the first efforts in the around 1990, around 1995 was the Scottish patient safety program, which achieved a 23% reduction in surgical mortality through the adoption of continuous improvement models in about a 5-year period, 2008 to 2013. This is applications in Brazil, a very active project now underway in Brazil on hospital complications called the PROADI Collaborative. They're working with about 116 here it is, public ICUs in Brazil, working on a collection of 3 areas of complication for patients in Brazil. It's all organized just like John Oldham's 11 centers for improvement in primary care. There are 5 hubs organizing the 116 hospitals, and each hub has its own support system. It's a deployed system throughout Brazil. Their targets are hospital-acquired infections, CLABSI, CAUTI, and VAP, central line bloodstream infections, catheter-acquired urinary tract infections, and ventilator-acquired pneumonia. Their goal was to reduce those complications 50% in 120 ICUs in the public sector. In 36 months, they have beaten their goal. This is the national data on central line infections, on CAUTI, and on VAP in that collaborative model, in each case, I believe exceeding their 50% goal. Collaborative improvement is a phenomenally powerful way if it's organized around the learning processes that the learning health system is described in the National Academy of Medicine reports. Right now, there's an interesting project that is directly relevant to nursing homes that some of you may know about. The Institute for Healthcare Improvement and the John A. Hartford Foundation have teamed up for this program, Age-Friendly Health Systems. The background here, initially started by Terry Fulmer, the CEO at the John A. Hartford Foundation, was to convene about 10 or 12 of the leading researchers on age-friendly healthcare. What does it look like? Many of these researchers have been supported by the John A. Hartford Foundation, and you know them, Mary Tinetti, for example, and about a dozen others. They came together and were supported to develop a framework that took a cross-cutting analysis of the literature, a little bit like the Preventive Services Task Force might do it, grading the evidence, and they ended up with the 4M model, which is the mainstay. That was developed in 2016 by the researchers with a bunch of practitioners. These are the 4Ms. The framework for change toward age friendliness is focused on what matters to patients. That's the first M. Find out what really matters to people and organize care around that. So it's a patient and family empowerment system. Focus on medications, especially excessive and overuse of medication and medication errors. Mentation are a whole set of interventions around people who are losing cognitive capacity, and mobility is giving people an opportunity to be more mobile. These 4Ms emerged from the literature as the 4 process areas to focus on. What didn't cover everything? I'd say it covered about 80% of the evidence-based portfolio for age-friendly care. The initial project in 2017 and 2018 involved 5 organizations that agreed to be prototypes for attempting to bring these age-friendly characteristics into some or all of their system. And because they worked on it for a year, they generated both specific examples of application in patients in settings and corrections to the model so that it became better in their hands. It's taken off now. This is the stage setting period. And then you see here enrollment. These are hospitals and practices adopting age-friendly processes now. It's now gone over, this is not up to date, it's gone over 1,000 now, and soon will be almost doubled. And this is done through that approach of learning and model development. There is an intent, by the way, just to tell you, to expand the 4M model, if possible, into nursing homes. This is the phase of adaptation of that and then deployment. I'm not saying this is relevant to your committee. I just want to say that the model development and the concept it's portable. I think the improvement approach is portable into the nursing home setting. So you sent me a bunch of questions, as I said, and now I'll try to go through quickly my responses and then get to your questions, to your dialogue. You sent me a few more than these, but I picked these 5 as ones I'll comment on from that framework, from the framework I just showed you. You asked me about priorities for institutional and post-acute long-term care, improvement priorities, lessons learned from attempts to use pay for performance, how to get more buy-in at all levels in the nursing home industry, what is the role of patient and family experience metrics in the above, and does the electronic health record potentially help us? I would say if I were on your committee, I would say you have to start with AIM. And I think the question you asked, top priorities for institutional post-acute and long-term care, would be exactly this. You would produce a nursing home analog to the 6 aims for improvement. Possibly the 4M model will help you, but I'm not enough of a specialist in the field to know. But I think anytime your committee spends on developing very specific aims for improvement, and these should be aims as experienced by patients, families, and communities, not aims that are methods for achieving those. So it's not an aim to say make reimbursement of nursing homes performance-based. That's not an aim. An aim is to reduce morbidity from medication errors and misuse in nursing homes, for example. I don't know what they would look like, but I think the 6 aims could be a good starting place for you. And then among those, it would be great if the committee would say there are 6 here, but we want to start someplace. And the 2 places I would start, given what I've seen in the nursing home industry, is I would put something in about what matters to you care, orienting the assessment and definition of quality in nursing home care more with much more power to patients and families, much more. And second, I think there's waste in the nursing home industry. It's such a starved industry for money. I mean, I just can't believe the budgets nursing homes operate under. So that means finding waste and getting out of there is absolutely crucial. It's one source of fungible money that I think probably should be solved. This would be an example, prioritization. I want to put this on the map because this is personal. I think the nursing home industry is tyrannized by policies. The rule basis is stifling to creativity, patient-centeredness, safety even, and certainly a comprehensive view of quality itself. Now, I'll tell you, the personal part of this is my brother. My brother had surgery early this week, and he has to go to rehab for his own safety because he has trouble walking now as a consequence of the surgery. He's been in rehab before. He knows exactly the right place to be for him, and that place had a space. So he was offered the space, and then they called back and said, oh, you can't come here, it turns out, because a certain drug he's on, a very important drug he must take, it's a life-preserving drug, is not on their formulary. And my brother said, that's no problem. I've got the drug right here. The bottle's by my bedside. I'll bring it and I'll take my own pills there. And their answer was, you may not do that. It's against our policies. That is, make that the first entry in a list of rules in the nursing home industry that impede sensible patient care. And if you want to find those rules, ask some families, ask some patients, and ask some staff. That would be improvement. We didn't put that on the framework for 6 aims in the IOM frame. We might have, but I think in this industry, it matters. And then here's another one that I'd like to put under your consideration. There needs, of course, to be a significant role for patient safety aims, but it must be placed in balance with other valued dimensions of quality. It's never right to give any quality dimension a trump card. And right now in the nursing home industry, because of the way the inspection apparatus has been oriented, patient safety is a trump card, I believe, that impedes other valued dimensions of care, such as visitation, family encouragement, mobility, even experimentation. So I would take a close look at this. As for all IOM committees, NAM committees, you want to find an empirical basis for my somewhat offhand assertion. I had another relative in a very fine rehab hospital, and I went and visited him, and I said, "How's it going?" And he said to me, "It's all about falling. They're so scared I'm going to fall that nothing else goes well here." Second question was, what have we learned from pay for performance demonstrations? The honest answer is not much, not enough yet. We've had at least a decade since Kathy and I were in the administration, of course, under the Affordable Care Act. A number of pay for performance demos were value-based payment demos went into place, a whole zoo of them, actually. They've not, in my opinion, been studied thoroughly enough, but here's what I think we can take away so far. No one has found a pay for performance model that makes any but marginal gains. Even the most fully developed of them, in my opinion, the Accountable Care Organization, is looking at, I don't know, 1, 2, maybe 3% gains in finance with some improvements in quality. On the other hand, we do know that you have to be careful. You get what you pay for. And if you pay for something, you're going to get a lot of it, as in that story about falls. Since CMS and others put very high penalties or stakes on high rates of fall, or even any falls in nursing homes, you get the overdevelopment focus on patients not falling at the expense of lots of other desired attributes because the rule book now says you can't fall. I myself would recommend a different vocabulary. I don't think paying for performance, which is an incentive-based idea, would be as powerful as paying to support the care wanted. Don't ask what's the incentive, ask what's the opportunity. Under this payment scheme, can a willing nursing home put its money where it really would matter? Not are we making them do it, but are we allowing them to do it? Overall, I think I'm willing to stand on the assertion that probably fee-for-service payment is not helpful, that we need to think in a different way about people's journeys through care and about population investments. Third question you had is, how do you develop meaningful buy-in for quality improvement? I've shown you. I mean, look at that Pro-Adi work in Brazil, or what John Oldham did in England, or what's been possible in Scotland. In none of those cases was there incentive-based buy-in. It was all invitational buy-in. It was setting up a system in which people, organizations, and individuals saw the opportunity to learn something they wanted to do better. Now, I'm not naive enough to say there aren't some jerks and miscreants out there. They need to be separately dealt with. That's that flat tire part of the curve. But if you want to improve nursing homes in America, draw on the desire of people to be proud of their work and and do buy-in by pull-in, by attraction in a learning system. I do believe collaborative improvement models are pretty powerful, and we could go into more of that in your Q&A now, but I think it could be done. I believe there is one taking form now at IHI with ARC, but I don't have the details on that, but I've become aware of it through reports at IHI. And then we have CMMI, which I got to set up when I was administrator. I don't think we ever nailed down bold long-term care redesign, development of total new models of long-term care. I mean, really revolutionary models as a possible investment for CMMI. CMMI tends to have been captive about models for payment, but I believe if perhaps in a Biden administration, there would be a chance for a portion of CMMI resources to go into thoroughly ambitious, comprehensive, bold redesigns of what long-term care is, especially, of course, long-term care at home. What I would think would be a useful way to organize thinking about how to make nursing home care better would be go back to the Duran trilogy and say, well, how are our control systems? Do we find the flat tires and do something about it? Do we support the learning of the industry as contemplated in the Learning Health Organization reports of the National Academy? And could CMMI or some other function help create an American agenda, maybe a 5-year agenda for creation of the completely new nursing home? Or maybe, ideally, we discover that they're not needed at all. Patient and family experience measures, well, it might be evident to you from what I've said so far that they're, to my opinion, in my view, they're absolutely central, because I believe this framework, asking what matters to you, is the best possible guide to improvement. I think we're going to have to get into rule breaking. I think a healthy step for this industry is to find stupid rules that don't really help anybody, that have been mapped into the industry, rules that have now become habits. And I think a forensic look at this, an interrogation of the industry for rules that are dumb, will help. Patients and families will tell you the rules that are dumb. So will staff if given an opportunity. Finally, is the support to the nursing home workforce. You can't get patient and family experience as a central point in a demoralized or under-supported workforce. And I'm thoroughly convinced that the conditions of work in the American nursing home are unsupportable if we want improvement. They just are unsupportable. I did look in the Biden-Sanders Unity Task Force at wage rates, benefit structures, and poverty levels in the nursing home workforce, and it's really stunning and shocking. The last question I'll tackle is the role of the electronic health record. I would broaden that question. I don't think it's the electronic health record that would be the right entry point. The right entry point would be idealized design. Go back to that proposal I'm making that CMMI be assigned the job of supporting an experiment to develop 20 perfect nursing homes or something in the world, in the US. Then from that design, the design would of course begin to use electronic records, and I would pull the record into the design of a more comprehensive system. This is the charter, I would say, support a large long-term care reinvention project offering an entirely new system, all the current status quo all off the table, and make the metric framework, the triple aim plus joy and work is the goals. And in the nursing home industry, especially support to the workforce among those goals. So that's more time than I should have spent. I'm sorry about that. I tend to rattle on here, Dr. Farrell, but I'm happy to take questions if there's any time.
Thank you so much. I think your comments are exactly the jumpstart that this committee needed. And I'm sure that throughout the duration of our work together, we're going to be reflecting on these initial thoughts. What we want to do now is to spend about this, we have about 15 minutes for questions, and we'll use the hand raising function, and Caitlin will be calling on members to ask questions. So Caitlin, I'll turn it over to you.
Thank you, Dr. Farrell. The first hand raise we have is Assistant Secretary Greenlee.
Don, thank you for the shout out. It was wonderful to serve there, especially when you taught us during staff meetings. We learned a lot at our time at HHS. I have a comment, kind of question about CMMI. I mean, my understanding of CMMI is that it's funded with Medicare dollars. And so they might be able to drive change with regard to Medicare post-acute care, but can they help us with Medicaid long-term care residents? Because that is really where we need some of the most significant change on some of the quality inspection issues that you were talking about. Can CMMI get to both populations?
Yes, I'm the one that put the second M in CMMI. It's Medicare and Medicaid innovation, and it's totally within the bounds of the statute. So yes, there's authority to do that. You can have Medicaid projects. Indeed, some of the most important stuff CMI supported was in the dual eligibles where Medicaid had a role. But Kathy, I think the fair answer is there's a political dimension to that, which is Congress tends to care much more about Medicare and the trust fund than it does about Medicaid. And so you have to make the case for it, maybe. But a friendly HHS secretary and administrator and CMMI director who wants to push toward Medicaid demos has the authority to do it. I'm almost positive about that answer.
Thank you.
Thank you so much. Next is Dr. Scanlon.
Hi, thank you very much, Dr. Berwick. It was very helpful, and I agree with you completely about the idea that we really should invest a whole lot more in improvement and be thinking boldly. But I also wanted to make sure we sort of come away in having your sort of perspective in terms of the importance of what you said toward the end about fixing the flats first. That there is an element for control that is critically important. When I was at GAO, which was about the same time as the Institute of Medicine was doing sort of the first reports on quality, we were looking at nursing homes. And what we were finding were that in about 15% of facilities, there were actual harm happening to residents. And it was actual harm that wasn't sort of rules that you would think of as arbitrary or ill-conceived. We gave the instances of actual harm to clinicians like Frank Williams, who was at NIA, and Sid Katz, who had developed ADLs. And their sense was this was basic care principles that were not being followed. It was not an error, but it was prolonged sort of neglect of basic care elements. And so, I mean, I'm thinking that we want to make sure we have the right weights that we attach to things. And as I heard you say, fixing the flats, don't overemphasize the flats, but fix them first and then make sure that you're bold about sort of improvement.
Thanks, Dr. Scanlon. If I said fix the flats first, I misspoke. It's not. It's more important to have improvement work going on simultaneously. So I meant only don't let the really bad stuff go on while you're working with the bulk of people on improvement. So excuse me for maybe misspeaking. So let me just make a couple points about it. First, I very much doubt that 15% of nursing homes are doing harm. I think the number is 100%, because healthcare is a complex enough enterprise. You can be absolutely sure there's a patient being harmed in every nursing home in this country every single day, maybe 10. That's just how healthcare works. And so the agenda, for example, of patient safety is not an agenda of flat tires, it's an agenda of the current characteristics of the overall system. And I think if one of the problems of focusing on just those ones you think are really doing bad is everyone else gets off the hook, and you don't want to do that. So this simultaneous front of continuous improvement in the entire industry while working on the really egregious failures is really crucial. But two caveats to that. One is, if the failure, the control mechanism, that red area, the quality control stuff creates fear, you're dead. You're dead in the water. You cannot induce continuous improvement in the entire industry in an atmosphere of fear. And this is a subtle matter. It means that one has to run the enterprise of what you're trying to do in this committee, making care better, by finding the really bad places that need something done, but not scaring everybody as you do that. And that's a very tough job. Second is I would say almost empathy. So yeah, when you're a surveyor and you go into a nursing home and you find something that just is terrible, you get angry and you say, how could you possibly do that? How could you possibly be so neglectful of this or that? The answer is because that's the way the system is. Most of the time, people, even in those circumstances, are doing what makes sense at that moment. And the adoption of a systems view of that problem instead of a police view of it is a really important thing to do. It's almost empathy with the field. I would get together 10 very poorly performing nursing homes in a room and say, what's going on here? Why is this happening? Can you explain to me what the circumstances of your lives or your environment, or what is it that does this? And hear them out, because most of those people are still good people trapped in something that was really wrong. Occasionally, there's a saboteur or a real murderer or a really greed-driven system, and then you just need to take out every possible legal tool you have and get them to stop it. But most of the time, even what offends you because of its obvious bad nature has a cause, and the cause can be very deep and once looked at, it's kind of easy to understand. That's my view.
Dr. Galambos. You're muted.
Dr. Berwick, thank you very much for that very informative presentation. I have a comment and then a question. My comment is, as I'm listening to you, I remember some of the work that I was involved in with JACO, where we were trying to look at developing a more mentoring approach to the survey and inspection process than a punitive approach. And some of what your comments really resonate with the work that was being done back then. My question is, it really resonated with me, your comment about there needs to be a significant role for patient safety aims, but balanced with the other goals, such as visitation and family engagement, and that the main focus has been on medical and safety issues. What I'm hearing you say is it's primarily maybe a regulation change, or at least that's what came out in your talk. My question for you is, what about reimbursable services? Do you see this impacting the increased focus on health and safety? And if we were to change the reimbursement structure so that the patient care and social care were emphasized equally, do you see that maybe making a difference in the future?
You know, I think it's a great question, Dr. Galambos. I would say it's, I don't know the answer for sure, and I think that your committee could probably do some good research or background, harvest the research on that topic. I think that when you have an inspection attitude, an inspection regime, and the inspector puts out, a goal, it does acquire focus. So I think some of what we observe is derivative from the way the regulations and inspections and even penalties, payment penalties, have been adjusted. For example, I know I was at CMS, I ran CMS, that the patient falls issue somehow reached the top of everybody's screen, and it became almost an obsession. And I don't want patients to fall, but the patient I know who was in that rehab facility was tied into a wheelchair so he wouldn't fall, when his real job was to gain muscle strength and get back home. And there was a clear misallocation of energies. And the staff were just doing what the reg said to do instead of thinking about what this person really needed. We would need a regime which says that sometimes people fall because they're taking a risk that we absolutely all want to take. Another example right now that's playing out in the COVID sphere, I don't know what Kathy and others think about this, but I think we got it wrong on visiting in nursing homes. I think we slammed down on nursing homes, keeping loved ones from their aging or even dying parents because of the trump card that COVID has. And a wiser solution would have been, well, no, there's some risk that we have to be able to tolerate so love can occur and touching can occur and people can be at peace. And if we can protect staff, we can protect visitors. But once you get safety on the screen, it becomes this sort of, it just trumps everything and it causes harm. I'd love to see your committee come out with some recommendations on loosening visiting restrictions a lot, even in the COVID era, because it's the humane thing to do.
Dr. Travers?
Thank you.
Thank you, Dr. Burrick. And along the lines of some of the discussion that has been had already, you talked about broadening the view from pay for performance to pay to support the care wanted. Do you have thoughts on how we measure that, as this view would become quite individualized? Do we base it on resident and family satisfaction surveys, similar to patient satisfaction surveys in acute care settings, to better hold nursing homes accountable in this area? And then I think about payment to nursing homes, and our current payment models do not provide enough payment needed to care for the resident. So how will pay for performance or pay to support the care wanted address the underfunding of nursing homes to begin with?
It's a deep question. So first, I would tend to avoid accountability language. I think there's a way to think about support, like how can we make it help? How can we, the payment on the payment side, be helpful to nursing homes doing the right thing? It's not an accountability issue. That's what I was trying to say. It's a support issue. So what would that look like? You want to know how we're doing. Well, I would say we still want to measure, and I would say that's where the patient-centered measures come in. Absolutely, I would embed patient reported outcome measures, patient-reported experience measures in nursing homes, absolutely across the whole country. But even more, I would talk to patients. I think there are dimensions of this that have to do with governance. I believe nursing home boards, for example, corporate boards, should always have either patients or patients' families on the board seats. I think every improvement activity in a nursing home should have seats for patients and families. In other words, it's not just a measurement issue, it's a voice issue, and embedding the voice of people in the system is a way to get closer to making sure the right thing happens. Then when something doesn't happen correctly, when there's no support for it, the people that really depend on it will get a chance to speak up and say, wait a minute, why are we forgetting X? I'm sure there are specific payment changes I should be able to elaborate into. One of them is a different view of the way the workforce is paid. I think that I just do not see a route to the kind of compassionate, excellent nursing home care we want in the current way we treat the lower paid people in nursing homes. And I think there has to be a complete reconsideration of those standards and the expectations about how the employment system will work, for example. So you've asked a deeper question than I've given justice to, Dr. Travers, but I'll think more about it.
Dr. Farrell, I don't see any other hands raised.
There is a comment there about litigation environment, by the way. It's part of the answer to what Dr. Travers just said, because when the malpractice and liability system is off kilter, then you get this cascade of effects of overinvestment in certain forms of rules. So that's quite an apt thing. You may want a chapter in your report on the malpractice environment.
Thank you so much, Dr. Berwick, and thank you for our panel for all of the questions. We also want to thank those who have joined us in this open session as participants. The committee will now be taking a 30-minute break, and then we will be resuming our work in closed session. And once again, Dr. Berwick, we're so grateful for all of your thoughts that will give us so much opportunity for reflection as we begin again in just a short period of time. So we really thank you for all of your contributions over the years, but particularly for being available to start our committee work. Thank you, everyone.
Thank you. Thanks, Dr. Farrell. Good luck on your very important work.